Thank you for joining Part 2 of the Buprenorphine treatment, a training for multidisciplinary addiction professionals. Dr. Broyle will now start the webinar.
Thank you, Christine. Christine, can you assist for one moment, please, in modifying the screen? Thank you for your patience. If you could bear with us for just one moment. Okay, thank you. I think we're ready to begin now. Okay, thank you all for joining us again today. Today we're going to be doing modules 3 and 4 of this training. Module 3, which is what we're going to start with, is Buprenorphine 101. I'm going to use the similar format to last time, where I'd like to take a 5-minute break in between modules 3 and 4 at about the 1-hour mark. Please bear with me today. I do have a cold, so if you do have difficulty hearing me with the audio, if you could please pop in a message to Christine, and we'll try to make some adjustments so that it's a little bit more clear for you. I wanted to take a couple minutes before actually entering today's content to follow up on some of the questions that we had during the last session. Dr. Silbert actually did some additional investigating regarding the yawning question, and I wanted to go ahead and give him a chance to share some clarifying information.
Thanks. Can you hear me okay?
Yes, I can.
Okay, fine. Anyways, it was a very good question, kind of caught us a little bit by surprise, and when I double-checked, there's been some ongoing controversy about yawning and the mechanisms in the brain, and Dr. Broyles and I, we probably gave you some wrong information. I've got to own up to that, because oxygen perfusion has been kind of debunked as a cause for yawning, and it turns out, even though some of this is still a little uncertain, that opiates directly inhibit yawning. So when there's a sort of agitated or excited brain, and all the neurotransmitters, and many of them were named in the research that I could find, including oxytocin and other sympathetic-like neurotransmitters, when they're active, the notion is that the brain goes into yawning to try to compensate for like overactivity and regulate the brain or the temperature in the brain. So there's still a lot of uncertainty, but the one thing we do know is that opiates, even though people can nod off, directly inhibit yawns, and when you're in withdrawal, you have an increase in yawning. Best I could come up with.
Great. Thanks for clarifying that. I'm sure we'll get that question again at some point in the future. The other piece that I wanted to follow up on was the question about the DEA audits, and specifically their role in assuring that providers, physician providers, are providing counseling as well. The DEA audits actually are really focused on making sure that providers are within their 30 or 100 patient limits, and making sure that physicians are actually prescribing the medication to patients who indeed have opioid dependence diagnoses. the audits are a little bit more complex. If you're actually dispensing the buprenorphine, you need to have safeguards in place and accounting of all of your tablets. In essence, good record keeping. But ultimately, counseling is not required. It needs to be available, which fortunately or unfortunately can be interpreted very broadly. You know, having the ability to refer, making contact information available to patients, and whether or not insurers require counseling is sort of a different issue. But unfortunately, just like any condition where counseling enhances treatment, say in the case of diabetic management, where nutrition or physical activity counseling or other management counseling has been demonstrated to enhance outcomes and is strongly advocated, it's still officially not required. So I just wanted to make that clarification as well. Okay, I'd like to go ahead again, and as Christine mentioned, please feel free to enter your questions during the session, and I will pause at certain points in the slides to take questions in that respective topic area. The module that we're going to start with today is Buprenorphine 101. Again, it's designed to provide an overview of the development of the medication and the pharmacology of it. We're going to go over how to use the medication in terms of the induction process, maintenance, and then medically assisted withdrawal or using it for detoxification. The primary focus of what we're going to be talking about today is to give an overview of the medical aspects of treatment, and then at the end we're going to talk a little bit more about non-physician providers' roles in each of those three phases of treatment. I do want to be clear, particularly when we get to the end of Module 4, where there's a video that we'll ask you to watch on your own later because of the difficulty in loading it onto the webinar. I just want to be very clear that we're not advocating buprenorphine as the only modality for treating opioid addiction. Again, the message that we want to send is that this is an additional option. It's not a replacement for or alternative for methadone. They're used in different ways, and different patients may be appropriate for those. So first we're going to talk about the medication specifically, what it is and what it does. We are excuse me, during the last session we covered the basics of opioid addiction and treatment, and we're going to talk now about the development of buprenorphine. We're going to compare the differences between the combination product, which is buprenorphine and naloxone, and the mono product, which is buprenorphine only. And then we're going to examine how buprenorphine can be used in each of those three phases of opioid treatment, as I mentioned. The medication was developed by a pharmaceutical company called Reckitt Benckiser, and they had exclusive marketing rights until the fall of 2009. They distribute the medication as Subutex, which is the pill on the left, and that's a sublingual tablet that contains only buprenorphine. The medication on the right is also a sublingual tablet. This is Suboxone, and it contains both buprenorphine and naloxone in a 4-to-1 ratio. So there's also a film version that is available. This is only available for Suboxone, and right now Subutex is available in generic formula. However, the Suboxone is not. The medication in general have a tremendous amount of research behind them demonstrating their safety and their effectiveness for treating opioid addiction. And again, that takes us back to the original premise from the last session about how this NIDA-SAMHSA partnership and blending initiative is really meant to be rooted in science. So during the development of the medication, the effectiveness of buprenorphine had been compared to other medications that were already available. So for example, the studies demonstrated that buprenorphine was more effective than placebo or sugar pill, and that it had similar effectiveness to both moderate doses of methadone and moderate doses of methadone and LAM. As I mentioned in the first session as well, a lot of treatments that are developed never end up making it into real-world practice, or if they do, it just takes a long time. And again, this is something that NIDA and SAMHSA have recognized. So the goal here is to bring this medication to the field more quickly as another important treatment advancement to make more options available for patients. So we do have clinical trial evidence demonstrating the effectiveness of buprenorphine for the treatment of opioid addiction. And the clinical studies have found the following. Patients on buprenorphine did as well as patients on a moderate dose of methadone. And when we talk about moderate dose of methadone, we're talking about the 60 milligram range. It's unclear, though, based on the existing research, if buprenorphine is as effective as higher doses of methadone, upwards in the range of 80 to 100 milligrams a day. Patients also who were on buprenorphine did as well as patients who were on a moderate dose of LAM, so like on a 70, 70, 85, Monday, Wednesday, Friday type schedule. As I mentioned before, LAM is no longer marketed in the U.S. Due to safety concerns. The third bullet here that was also uncovered during the research where they investigated patients' experiences, they found that patients found that taking buprenorphine was a pleasant experience. It has a mildly reinforcing quality, but not intoxicating or euphoric, which I'll talk a little bit about later in this session. But nonetheless, the mildly reinforcing properties did help with medication adherence. And then finally, when compared to placebo plus counseling, that particular combination, one study demonstrated that 3/4 of the patients who were receiving buprenorphine and counseling were still in treatment after 1 year. So again, just stressing the importance of the buprenorphine and the counseling, whereas in the other study condition, none of the placebo patients were retained at 1 year. So buprenorphine is what's called a partial agonist, or a mixed opioid agonist-antagonist. I'm going to go into that in a little bit more detail, but if you can just think back to the first session where we had the graph, and I used the analogy of the car accelerator. So there was the low line on the graph, one in the middle range, and then the high range. So the high range was the agonist, or the full effect. The middle range was this mixed effect, this partial agonist and antagonist. And then the low line was the agonist, where the effect was essentially blocked. I'm going to talk more about this partial agonist and what that means and what the properties are in a couple minutes. But again, overall, with the changes that were affected by the treatment legislation, buprenorphine had become the first medication that is available outside of the opioid treatment program system, again, expanding both availability for patients and access to treatment because it's available in a primary care or other setting. So again, excuse me, just to go back to refresh on the partial agonist properties of the medication, this is really important to understand. The effect of buprenorphine at lower doses are virtually the same as those of full agonists, like methadone. However, as the dose of buprenorphine is increased, the effects level out, particularly respiratory depression, whereas the effects will increase and continue to increase with full agonist medications. And so buprenorphine's leveling out effect, again, particularly with respect to respiratory depression, is called a ceiling effect. And that quality of the medication really helps decrease the risk of overdose when compared to full agonists like heroin or methadone. Buprenorphine also has a really high affinity for the opioid receptors. So thinking back to the lock and key type mechanism, it displaces methadone, morphine, and most of the other full agonist opioids from the receptor. It will, in essence, knock them out of position, knock them out of that lock and key connection. So buprenorphine binds tightly, and it stays bound in the receptor and dissociates very slowly. So it comes off that receptor after a very long period of time. So this tight binding and the slow dissociation from the receptor mean that buprenorphine is able to block the effects of other opioids such as heroin. So what that means in plain language is that when buprenorphine is sitting on those opioid receptors and is locked in, it is going to block the effect of another opioid if someone were to use heroin on top of the buprenorphine. They won't feel the effect because the buprenorphine is too tightly bound in that receptor. And additionally, the fact that it binds so tightly and takes so long to come off the receptor speaks to buprenorphine's extended duration of its therapeutic effect. As I mentioned before, the clinical trials have demonstrated that it's both safe and effective for long-term opioid maintenance as well as medically assisted detox as well. And because it's very long-acting, dosing can be set on a less than daily basis, sometimes as infrequently as 3 times a week. So I want to go over some of the advantages of buprenorphine so that you get a sense of how it can be used and the people for whom this may be most appropriate. The goal when you're using medication-assisted treatment is to help people start to engage and participate more fully in their treatment activities rather than being sick from withdrawal and kind of disengaged for several days. So what this means is that when patients are being transitioned onto buprenorphine, they can begin the cognitive or the emotive portions of the recovery process as they can begin them as soon as they start to seek treatment, when their motivation is high. And so it can help close some of that gap between motivation and actual treatment engagement. There are no known cases of overdose that has been directly related to buprenorphine. And so this is a very distinct advantage. The cases of overdose which have occurred had involved the use of alcohol or other respiratory depressants, for example, the benzos. In general, again, with respect to bullet 3, patients report minimal sedation or drowsiness following a dose of medication, which again helps them participate more effectively in treatment and also in many ways helps maintain their privacy that they are taking an opioid partial agonist. And finally, again, we can use this in the office-based setting, as I mentioned before. And then finally, there is a lower level of physical dependence with buprenorphine, and again, some patients are more comfortable with that. But there are also some advantages to the combination product, which I want to talk about. So the buprenorphine and naloxone formation has some advantages compared to just the buprenorphine only tablet. The combination product discourages injection of the medication because when it's injected, the naloxone in the combination will lead to withdrawal, whereas when it's taken sublingually as prescribed, the absorption is different and it doesn't precipitate that withdrawal effect. The combination tablet lowers the likelihood that the medication will be diverted. And then an additional advantage excuse me, to the combination formulation is that it allows for take-home dosing. There are also obviously some disadvantages to the medication that we want to cover as well. One of them is something that folks had mentioned during the last session, that buprenorphine is definitely more costly than methadone. According to the manufacturer's estimates, the Suboxone at 16 milligrams a day costs just over $300 for a month's supply, compared to less than $30 for a month's supply of methadone at usual doses or in the standard range of doses. Overall, as I mentioned back 2 slides ago, there is a lower level of physical dependence with buprenorphine, and while this is for the most part seen as an advantage of the medicine, it does make it a little bit easier for patients to discontinue treatment and return to use depending on what their circumstances and their addiction profile are. The third thing is that buprenorphine is detectable in urine toxicology screens, but it's not part of the NIDA-5 panel. So many tests will not detect it, and if you are taking buprenorphine, you will not screen positive for opioids. Special tests for either buprenorphine or its metabolite need to be ordered instead. And so it's one factor that needs to be considered so that adherence to the medication can be monitored. There has been a lot of discussion as well about the costs associated with buprenorphine. And as I think it was Dr. Silbert mentioned before, when you're considering the costs of providing buprenorphine treatment, you have to also consider all of the associated costs, which may include clinic visits and staff time and general facility operating expenditures as well. Some of the recent research that was conducted on adult populations has demonstrated that buprenorphine is cost-effective across several different indicators. And I'm going to just go over these studies fairly quickly, but just to give you an idea of, depending on which cost effectiveness or cost utility or budget impact analysis you do, you still get consistent results about the cost effectiveness of buprenorphine. So in 2003, Duran and colleagues in Australia conducted a clinical trial of about 400 patients in outpatient specialty treatment centers. And they were trying to assess the safety, efficacy, and the cost effectiveness of buprenorphine versus methadone specifically in the management of opioid dependence. And they used a flexible dosing regime that was tailored to the clinical needs of the patient, and they did their cost effectiveness analysis from the perspective strictly of the service provider, and they included costs that were relevant to the provision of treatment. Their primary outcome in the study, or in the economic analysis portion, was change in heroin-free days from baseline to 6 months of treatment. And what they found was that both buprenorphine and methadone demonstrated increases in heroin-free days, and that ultimately there was no statistically significant difference between the cost effectiveness for buprenorphine and for methadone. In another study, which was later in 2008, another set of investigators found that treatment with buprenorphine, with the combination product, was associated with both a reduction in opioid utilization and costs within the first year of follow-up. The same Australian researcher, again, Duran, later conducted in 2008, so 5 years after the first study, an overall systematic review of the literature and found a number of studies supporting that buprenorphine was a cost-effective approach to opioid treatment as well. And finally, another Australian study by a group of researchers led by Dr. Harris were the first to really examine the cost-effectiveness of buprenorphine in primary care patients as a maintenance treatment for heroin specifically. And the study was also randomized and open label. It was a 12-month trial of just under 150 heroin-dependent patients. And they were receiving, patients were randomized to either be receiving buprenorphine or methadone. This study took a little bit broader of a social perspective, and it included health and crime and personal costs as well. In this type of cost-effectiveness analysis, the main outcomes were the incremental cost per additional day free of heroin use, and then they adjusted that for quality-adjusted life years, or QALYs. QALYs are essentially a measure of the burden of the disease that calculates in both the quantity of life and the quality of life that are lived. It's used to assess the value for your money that you spend on a medical intervention. So the quality represents or is based on the number of years that would be added by having and by participating in the specific intervention, in this case buprenorphine. And they found that buprenorphine demonstrated both lower crime costs and higher quality-adjusted life years. So again, that formulaic calculation that counts both quantity and quality of life variables in it. So I want to talk for a moment about why the combination product was developed. In other countries where buprenorphine has been available, there had been reports of increasing abuse of the medication. So U.S. developers were trying to find a way to prevent misuse of the medication as much as possible. Since use of the buprenorphine naloxone combination product by injection will cause withdrawal, the likelihood that people will misuse it, or by the case where an out-of-treatment opioid user would use it, is greatly decreased. I want to talk also for a moment about the ratio of buprenorphine to naloxone in the combination product. This ratio is a 4-to-1 ratio, which was found to preserve the clinical effects of each medication when taken as intended, but it causes sufficient discomfort if it's injected by a physically dependent patient. And again, that's designed to discourage patients from doing that. The reason that this works is because buprenorphine and naloxone have different sublingual versus injection potency profiles. Essentially, if you were to swallow buprenorphine, the digestive juices would terminate its effects in the stomach and in the digestive system. But by administering it sublingually, where it dissolves under the tongue, it's absorbed directly into the bloodstream. But naloxone has a very different absorption rate when it's taken this way. So when the pill is taken under the tongue, the person receives about 40 to 60% of the available buprenorphine, but only 10% of the naloxone. But when you look at the relative potency comparing sublingual administration to injection, the buprenorphine is approximately twice as strong when it's injected as when it's taken under the tongue. Whereas naloxone, on the flip side, is about 15 times more effective if injected. So it means that if you inject the product, the naloxone is going to be the stronger medication. And in essence, those antagonist effects are going to dominate. It's going to, again, precipitate very uncomfortable withdrawals. Excuse me. The effect of the combination product is virtually identical to the buprenorphine-only product, the Subutex, when it's taken sublingually. And both formulations will demonstrate that ceiling effect at higher doses, and both are also going to prevent intoxicating effects if someone decides to use another opioid on top of the buprenorphine, again, because of that tight receptor affinity. Both are also long-acting because of that same affinity. They're going to bind tightly. All of these characteristics of the medication mean that buprenorphine has a much higher safety profile with respect to overdose than the other opioid full agonists like methadone. The maximum effects of buprenorphine appear to happen in the 16 to 32 milligram dose range for the sublingual tablets, and higher doses have not been shown to produce greater effects. So it's really unlikely that going much higher is going to give more effect, because at 16 milligrams, I believe it's about 95% of the receptor sites are full, and then at 24 milligrams, it's about 99%, almost 100%. So you're not going to be able to pack any more receptivity of the medication into your neurological system.
Laura, I'm going to jump in for 1 second.
Sure.
I'm going kind of partly by one of our West Virginia U friends and colleagues and experts, but Dr. Sullivan really believes that the higher doses of anything have led some folks to feel worse rather than better, and that's why some ineffectiveness in the circumstances when you see some folks on 32 milligrams or even more than 32 milligrams has occurred. So it's probably food for thought or for research, but there's certainly no advantage known to the higher doses.
Thank you. That makes sense. It's always good to have some local data as well. The other aspect of overdose that I want to highlight once again is just that reduced risk of respiratory depression from either the buprenorphine alone or the combination product. There hasn't been any evidence to date of organ damage with long-term use of buprenorphine, but sometimes there is evidence of increased liver enzymes, and so that does need to be monitored. There's also no evidence of any significant disruption in someone's cognitive performance or their psychomotor abilities with buprenorphine maintenance dosing, so that's important to remember. And finally, the side effects of buprenorphine are going to be similar to those of other opioids. They're going to include nausea, vomiting, and the effects on the GI system like constipation as well. One of the important things to remember is that both the mono product and the combination product can precipitate opioid withdrawal, and that can happen in folks who are maintained on buprenorphine. Before I go on and start talking about the three phases of opioid treatment, the induction, maintenance, and then medically assisted withdrawal, I'd like to pause here for questions.
Okay, I have two in so far. The first is, can you explain the 4-to-1 ratio, please?
Sure, let me go back to that slide.
That question was submitted before you had done the slide, so
yes.
Some of it may have become apparent as you gave the slide.
Does that question, does the person that submitted that question, can you indicate whether you need some additional information, or did the slide suffice?
The second one, I think, was also submitted before you got to this section. Some people will say that if injected, Suboxone produces a high. Is this factual?
Well, I'll make a stab, and you can certainly kind of chime in or disagree, but certainly I'm not aware of anybody who was using the Suboxone product rather than the Subutex product who ever reported that. It wouldn't seem factual because of the blocker. When I saw that question submitted, I tried to imagine, would there be any impact for a person who pretty much never ever had done opiates at all and then did an injection, but I would still think that the blocker would prevent any significant euphoria or high from occurring. So I don't think it's factual for the Suboxone formulation. It may well be, and I've heard many reports of it with the Subutex formulation.
Okay, there's a follow-up here. It says, will Subutex cause a high then?
And again, kind of similar to what Dr. Broyles has already been, teaching. It depends on what individual we're talking about. If an individual never ever had done, opiates or opioids and is kind of drug abusing in order to get high, there could be some euphoria, though certainly less than what's noted with most, if not all, other opiates. So there can be, as she taught everyone, a limited sense of well-being or euphoria. Certainly, to my understanding, and I think some research understanding, less than even when compared to methadone.
Okay, and that's it?
Yeah, just to echo Dr. Silbert's comment, my inclination would be to answer the same way, that you would probably have to be talking about a relatively opioid-naive individual. And again, you would still get, you're going to cap out on, you're going to have a ceiling effect in terms of any euphoria, even if injected, and it would have to be a pretty opioid-naive individual. These are great questions, though. Thank you. I know diversion has been a concern for the group, and so I appreciate these questions that raise that issue.
Okay, I have one more that just came in. Do you want to take that now or wait?
Fine with me.
Okay. What are the implications of either product in the workplace regarding safety?
Yeah. Well, I have one twist with that, and I think we may have touched on this issue and probably will before the end of all the modules, and that is, personally, I think that a lot of individuals' cognitive functions would have so little deficit, so little problems caused by being on the medication, and if you compare that to the cognitive problems and functioning problems they'd have certainly under the influence of any other opiates or drugs of abuse, that I see it as fairly safe being utilized by individuals in the workplace. I know there's always exceptions and ways with combinations with benzodiazepines or where it would add to problems, but if we were talking about a well-maintained and monitored person on buprenorphine in the workplace, I think it would be okay. The only other thing I'll add, and it's sort of a little bit of a pet peeve of mine, I work a lot with healthcare professionals, and right now, at least in the state of Pennsylvania, you can't be under a monitoring program or retain your license and be officially actively taking buprenorphine maintenance treatment. That may change in the future, but right now we won't be kind of having our surgeon or internist or even psychiatrist under medication-assisted treatment.
And Dr. Silbert, is that limited just to healthcare professionals, or are there any other professions that have elected to choose those parameters? I'm thinking of pilots or other transportation workers or people in other high safety related occupations.
Right. The pilots have a, and I just found this out recently because the rehab I sometimes help out at has started a program with pilots, and they have a similar monitoring program to what the professional healthcare program, the physicians and other nurses, dentists, pharmacists have. So they look at it on a case-by-case basis, but I will get back to you after checking with the experts. Have they, allowed it only once or twice or never? I can try to get back to you on that.
Thanks. And what I'll do too is I have a colleague that runs a peer assist program in Colorado, and so just for comparison, I can also find out from her what their state's policies are as well. Thanks.
Sure, and again, just to illustrate the point about safety, I mean, I certainly sad to say no, because I've treated some of these individuals, surgeons, including gynecological surgeons who did surgery under the influence of their narcotic dependency and made some serious mistakes, even leading to malpractice litigation that I'm convinced they never would have made if they weren't under the influence of those drugs of abuse.
Thank you. That's a good point. Okay, what I'm going to move into now is talking about how people are transitioned onto buprenorphine through the process of induction, and then look at the two primary treatment options, the two ways that buprenorphine can be used, either as an ongoing maintenance or medically assisted withdrawal. The term induction refers to the set of procedures that are used to transition someone from other opioids be they prescription opioids or heroin, onto buprenorphine. And during induction, the physician is the one primarily working with the patient to figure out the most effective dose so that the patient can stop other opioid use with minimal withdrawal symptoms. While this part of the process is primarily guided by the physician and directed by him or her, the rest of the multidisciplinary team is really critical during this time period in providing that supportive care, being present, being active, and starting that counseling process to not only help the patient through the detoxification process, but firmly establish those connections that are going to help with the long-term recovery process. There are, excuse me, 3 ways that a patient can experience withdrawal symptoms while they are being transferred onto buprenorphine. The first way is if their dose is too low. So if an insufficient dose of the buprenorphine is given, the person may experience withdrawal because essentially they're under-medicated. Essentially they are getting insufficient amounts of the agonist effect, and they are not receiving enough coverage of those opioid receptors, and therefore they're experiencing withdrawal. If the dose is too low, they're going to experience withdrawal again because those opioid receptors aren't covered. What this graph really shows is how being under-medicated can cause that withdrawal. If the patient is given a low level of medication, which is represented on the graph in the blue, but they need a higher level so that they don't feel sick, then they're going to feel sick unless their dosage is increased to bring them up to that level. The second way that patients can experience withdrawal during transfer onto buprenorphine has to do with the properties of the medication itself, that ceiling effect. So if the person needs a high level of medication to reach a maintenance level, then it's the ceiling effect that's going to cause this. So as described before, as the dose of the buprenorphine increases, the agonist effects are going to plateau or level off. And for somebody who's dependent on really high doses of opioids, they may need an effect that is greater than what can be achieved by the buprenorphine in order to not feel sick. So in this case, someone is more likely to need treatment that is going to involve a full agonist like methadone, or they're going to need to taper down their level of drug use first to a lower level before transitioning onto buprenorphine. And this is traditionally done in a structured context within the confines and parameters of an opioid treatment program, but it shouldn't be attempted with someone who's using illicit opioids because it's just too difficult to taper down with precision and titrate down. So the person really needs to be transitioned onto methadone and then onto buprenorphine once they come down. The third way that someone can experience withdrawal during the transition is through precipitated withdrawal. And again, this has to do with the ceiling effect and also with the receptor affinity, or how tightly they're binding. So if somebody transitions immediately from heroin to buprenorphine, the buprenorphine is going to replace the heroin at that receptor, and the patient is going to have the experience of suddenly having fewer opioids in their system than they're used to. In essence, the buprenorphine is going to, because it binds so tightly, it's going to knock that other opioid off the receptor and throw the person into withdrawal. If somebody's already in mild withdrawal, you do want them to be a little bit sick. The buprenorphine is going to have the expected agonist effects that you want, and the patient will have a comfortable transition. This is one reason why it's really important to make sure not only that your patients are a little bit sick in terms of opioid withdrawal when the buprenorphine is started, but also to make sure that they're not using methadone or any other opioids on top of that. That can really complicate the whole transition process. If the person is currently intoxicated on an opioid, the opioid receptors are already filled with that drug. But again, the buprenorphine is going to have a stronger affinity for those receptors. It's going to bump them off the receptor, and because of that ceiling effect, the patient is going to experience this as a rapid reduction in the amount of opioids in their system, and they're going to experience withdrawal. People who are using either short or long-acting opioids can be transitioned onto buprenorphine, and it's really important for the patient to partner with the physician during this process, while at the same time having the rest of the interdisciplinary team ready and available during that process to provide the supportive counseling and transition into more comprehensive recovery. The person has to have abstained from their short-acting opioid for at least 6 hours and be in mild withdrawal before starting the buprenorphine. The video that we're going to ask you all to watch at the end of Module 4 is based on patients at the Oasis Clinic in Oakland, California, and that facility actually has a policy where you need to be off opioids for 24 hours and in much more significant withdrawal. Some of those decisions are made on a facility-by-facility basis, and thus the recommendation is really that they need to be off opioids for at least 6 hours, not necessarily up to 24. It's best to, instead of going by some kind of arbitrary time frame, to really use a structured instrument to evaluate someone's withdrawal symptoms, and you can do that with the COWS, the Clinical Opioid Withdrawal Scale, to give a more objective rating to the clinical signs and symptoms that patients are experiencing. In general, clinical experience has also demonstrated that for folks who are on longer-acting opioids, say who are on methadone, can be transitioned successfully onto buprenorphine using similar procedures, but just need to, in this case, make sure that you are closer to that 24-hour period of being free from the longer-acting opioids. In this case, patients are usually started on a very low dose of buprenorphine, around 2 milligrams, and then they gradually receive more if needed. Once the person is stabilized on the medication, once they're on the medication, it's important to make sure that they are stabilized. And by stabilized, we're essentially just saying that they're experiencing no more withdrawal symptoms, any negative symptoms, side effects, or cravings. And at this point, the decision can be made to either move the patient on to the maintenance phase or to withdraw them with medically assisted withdrawal or structured detox. The goal of maintenance is complete cessation of illicit drug use and also alcohol use. And it's really important for the providers and other treatment professionals to really assess any underlying issues as well that could lead to cravings or relapse. So this includes psychiatric comorbidity and other psychosocial issues like legal, family, employment, all of those issues that can contribute to relapse. During maintenance treatment, excuse me, providers really need to comprehensively assess all of these issues and incorporate them into the treatment plan so that the patient is able to become socially and emotionally and physically stabilized and then ultimately progress through recovery. Maintenance treatment can be very short. It can be less than 12 months, or in some cases, it may be a lifetime process. The research and clinical consensus from the Centers for Substance Abuse Treatment suggests that the longer that patients are maintained on medication treatment, be it methadone or buprenorphine, the higher the likelihood is that they will experience less illicit drug use and also fewer physical and psychosocial complications. So I want to speak for just a moment about the process of take-home dosing. It is desired by a lot of patients, but it's really important for the treatment team to remain engaged with ongoing monitoring to really make sure that the person is adherent to the treatment regimen and the way that the medication is supposed to be taken and not being diverted. In adults, it's not necessary to have Q-day dosing or everyday dosing. There has been research to support that a 3 times per week dosing schedule is safe and effective and adequate for a lot of people. And there just hasn't been enough information about less than daily dosing to make that full recommendation for adolescents, however. Ultimately, as we said before, the pills aren't going to teach the skills. And so it's really imperative that counseling be integrated into the treatment plan and really supported by the entire multidisciplinary team, understanding how the medication works and that it's one piece in this mosaic of treatment modalities. So in terms of medically assisted withdrawal or detoxification, once the patient is stabilized, we need to consider that not all patients are going to be appropriate for withdrawal from the medication. If someone has unstable living conditions, if they've had multiple relapses or lack of prior success with detoxification attempts, or if they just in general have a limited desire to come off of opioids, it may suggest that maintenance on a longer-term basis would be a better and more appropriate treatment option for them. But if it is appropriate to go ahead and transition someone off the buprenorphine, excuse me, then the goal is to help transition them off the buprenorphine just as comfortably so that they're no longer physically dependent on the medication. Psychosocial, adjunctive therapy and treatment components are really critical during this transition period, again, to help people avoid relapse and really help them remain firmly engaged in the rest of treatment aside from the medication aspects. It can be done in both outpatient or inpatient settings. Both can be successful, and it's important for the team to have these supportive wraparound stages to get patients through what can be more often a psychologically challenging experience as opposed to a physically challenging experience. It's sometimes indicated that other medications may need to be used if there are withdrawal symptoms that do arise to help the patient stay comfortable. And again, those would be some of the non-opioid options to treat individual symptoms of withdrawal. Again, clonidine, ibuprofen, antiemetics or anti-nausea medications, just to treat those individual symptoms. So to wrap up this module, the take-home points are really that buprenorphine is available, that it does have the randomized controlled trial evidence behind it, which has demonstrated its safety and its effectiveness. And regardless of which manner in which buprenorphine is used, whether it's for long-term maintenance or medically assisted withdrawal, the multidisciplinary team is really key in helping patients transition or maintain. It really helps maximize patients' long-term success. So we're right at about 3 o'clock. I'd like to take a couple minutes for questions if there are any that have arisen, and if not, we'll take a short 5-minute break and then move into the 4th module.
Hi, I do have a few questions. One of them is, I think, came in just at the very, very end of the last question-answer period. It says, did you say nurses can't be on medical-assisted treatment, I guess, in Pennsylvania?
Dr. Silbert, are you available? No, I believe that is what he said. I believe that he covered all healthcare providers, including nurses.
I forgot. I'm sorry, I didn't unmute myself, but I have in the past had nurses who were taking Suboxone or Buprenorphine, whatever you choose to call it, treatment, and it had to be specifically approved by their nurse monitoring system. But it was several years ago, so I would have to check back to see. I think it's never been an official position that I can recall, but I did certainly have a nurse or two as patients who were on Suboxone. So I believe it's different than it is for physicians.
Okay. And the last question is, I know inpatient rehabs will detox, maintain, and taper patients off buprenorphine before discharge. How do you think that they don't? Why do you think that they don't refer the patients to outpatient Suboxone treatment programs for continued counseling and medication assistance?
Well, this is one of my passions in this field. This question's awfully good, and if you went purely by outcome studies, you would think that was kind of a silly thing, not to do that, to just detox people off and not refer to an outpatient maintenance. The issue at hand, and I do have some empathy for the issue, is that many treatment providers, many rehabs have strong feelings that abstinence is the preferred way to go, that basically there's still many feelings that taking buprenorphine is somehow not as good as being in total abstinence, and they hold on to their philosophies that it's a must. And I kind of walk a tightrope, having a lot of tremendously positive feelings about what some of these facilities have done and many of the 12-step approaches. I'm a believer that if it was a very young person who wasn't exposed for a long time to opiates, maybe some of their neural circuitry hasn't changed, I do think that person should be detoxed and given a try at an abstinence approach. But certainly I've changed through the years, and watching people and many of the poor outcomes that sometimes are deadly, I no longer hesitate like I would have earlier in my career about taking the approach that the referral to the outpatient program should be done. So if it's a very new to opiate abuse or dependency person, feel differently about it. Many centers and philosophies just don't allow for that, so they do the detoxification with the buprenorphine. It's a very preferred agent for opiate detoxification compared to some of the previous ones and the regimens that were utilized.
And there's just one more. Can someone be induced on Suboxone if they are sober or not in mild withdrawal? And if so, what are the effects? Does the patient get a high?
I'm trying to think if there's data on this before I answer what I've seen in the office, but Lauren, do you know if there's data on pure sober folks? Like, you know.
I guess what I'm thinking of in the context where I have heard of this situation has been, for example, folks who are transitioning out of the criminal justice system who are at extremely high risk for relapse but have technically been opioid-free for some period of time.
Yeah. I mean, what I noticed in the office, and I'm not so sure if this is considered off-label or on-label usage, so that's my only hesitation in terms of some of the FDA criteria, is that when I would do that, you usually utilized very low doses of Suboxone, certainly Suboxone in that Subutex, and if you utilized 2 to 4 milligrams, and again, can I have a waiver here for the folks listening in? I'm not sure you can find this as a preferred approach in textbooks, but if you use very low dosages, there was some success in that approach with folks who had been off all opiates and sober from alcohol and benzos, and it did seem to make a difference in any leftover cravings they had and seemed to lead to better outcomes in their life.
Okay, thanks. We still have a couple coming in, but if you'd like to take the break, we can take these when you get back.
Okay, yeah, let's go ahead and take a 5-minute break to do email or other personal business, and then we'll restart right at about 10 after 3. Thanks.
Okay. And so everybody understands, we will be muting our phones too during this time, so don't get upset if you don't hear anything. Thank you.
Christine, can we get started again?
Yeah, that'd be fine. I'll make you the presenter again.
Okay, great. Thank you. I do want to stick to our time schedule so that folks who have allocated exactly until 4 o'clock can return to the rest of their day. So I'm going to go ahead and get started with Module 4. This is the module where we're going to cover how to determine and assess whether or not patients are suitable for this type of medication and whether they're most appropriate for treatment in an office-based setting versus an opioid treatment program. This is another place where professionals or providers outside of the physician need to have a good understanding of what the components are of this selection process so that we match patients to the right form of treatment for them. It's important for the non-prescribing addiction members of the addiction team, to be knowledgeable about this process for a couple reasons. So first is that frontline addiction professionals that are working with the patient during the rest of the recovery and treatment process are going to be some of the first folks who get a heads up about someone's appropriateness for treatment changing during the course of buprenorphine treatment. There may be factors that other professionals are the first to detect that then need to be brought to the attention of the physician. The second is that potential patients or other treatment providers may consult you as an addiction professional about patients' appropriateness for treatment in a curbside kind of consultation type of way. And then ultimately, though, it's just important to have informed communication and connection with the prescribing physician so that everyone is essentially on the same page, at least with the basics of the treatment process. So in this last 45 minutes, we're going to go over the components of the patient selection process. We're going to talk about the whole concept of opioid addiction and how a diagnosis is achieved, and then ultimately go into understanding which patients are appropriate for office-based treatment in particular. We're also going to talk about some circumstances where someone may not meet all of the criteria for opioid addiction and yet still be appropriate for office-based treatment. And this, again, may speak a little bit to the question that we had in the last section with respect to starting someone on a buprenorphine induction process who had been opioid-free. We're also going to go over some of the medical contraindications for buprenorphine, situations in which it should not be used. And then ultimately, we're going to ask you to watch the video later on your own. I think it's about 10 minutes long, which just gives some patient perspectives directly on the experience of being on buprenorphine treatment. So we're going to start with going over what the assessment questions are for determining who's appropriate for buprenorphine treatment, situations in which non-prescribing professionals need to consult with the treating physician, and then some other issues that are related to patient selection. So there are really a whole set of assessment questions that need to be considered. It, in essence, includes determining if the person is still addicted to opioids, if buprenorphine is in fact the optimal medication for them, and if an office versus a clinic is the optimal site for treatment. So it's really those three overview questions, or three overview issues need to be considered. And once a thorough assessment is done, then the physician can determine if addiction to opioids does in fact meet the criteria, DSM-IV criteria for opioid dependence, and really consider more in depth these 10 questions. So the first is the patient addicted to opioids? In general, you're going to use buprenorphine with people who meet criteria for opioid addiction, but in some cases, physicians may still consider buprenorphine treatment for patients who have problematic opioid use that hasn't fully progressed onto addiction. So an example might be if, in the physician's judgment, the patient has a really high risk of progressing to addiction, or they're already injecting opioids even though their dependence may not be fully realized. Other potential candidates might be, as I mentioned earlier, patients who had a good history of buprenorphine being effective for them, but then maybe had their medication discontinued due to incarceration, and they're now at a high risk for relapse. So, for example, upon release from prison. Second bullet is the patient aware of all of the other available treatment options? So even if someone is addicted to opioids and is a suitable candidate, they may not be most appropriately treated in an office setting. You really want patients to be aware of all the options and then help them make the treatment choice that is going to be the best fit for them. And ultimately, their willingness to participate in the program and all of its dimensions is critical to adherence to whatever treatment regimen or plan has been designed. In some cases, co-occurring disorders, particular psychiatric disorders or other medical conditions, or even in some cases other substance abuse conditions, may lead the provider to decide that the office-based setting is not most appropriate because that office doesn't have adequate capability to provide adjunct services that are needed, be it psychiatric treatment or comprehensive specialty medical care, et cetera. For example, again, someone who maybe has a severe personality disorder or needs comprehensive specialty care for HIV/AIDS is going to need additional services that that provider may not be able to provide to really ensure full recovery support. Related to bullet 2 is number 3. So not only is the patient aware of the different treatment options, but do they understand all of the risks and benefits and limitations of buprenorphine and what it will do as well as what it's not going to do. So it's important to assess whether or not there are indications that this patient is fairly reliable. Do they have steady appointment? Do they have the ability to show up on time for, do they have steady employment, and do they have the ability to show up on time for appointments? Are they taking other medications as prescribed? And have ultimately have the cost issues been explained to them, and do they realize what may or may not be involved in terms of costs for different treatment options? In a related vein, you want to assess whether or not the patient can be expected to be reasonably compliant and adherent to the medication. Are they going to be able to attend counseling sessions as required? Are they going to be able to manage the medication at home and store it safely? And will they be able to take it appropriately as prescribed? If the answer to those is no, then the team really needs to consider the possibility of either doing buprenorphine treatment in a highly structured environment like residential or partial hospitalization, or really consider a different treatment modality. And number 5, is the patient able to follow the expected safety procedures? Are they going to be able to keep it away from children in the home, store it safely, and again, take it as prescribed? This slide covers the rest of the other 5 criteria. Is the patient psychiatrically stable? Do they need to be stabilized first, or do they need treatment for co-occurring disorders? What order does that treatment need to happen in, and what capability does the system have to coordinate that treatment if it's going to happen concomitantly? There is a treatment protocol guide, one of the tips, tip 40, which is the buprenorphine treatment guidelines. You can order those online. And according to Tip 40, they want you to assess the presence and the severity of any comorbid psych issues before you start buprenorphine treatment, and really determine whether or not referral and coordination of care to specialized behavioral health is needed. The psych disorders that are most commonly encountered in opioid-dependent patients are obviously other substance use disorders, but also depression, PTSD, substance-induced psychiatric disorders, and then also some of the access to antisocial and borderline personality disorders as well. In the second bullet, it highlights the fact that you really need to consider any of the other medications that the patient may be on that could potentially interact with buprenorphine. So, for example, naltrexone, benzodiazepines, other sedative hypnotics. And another way of asking this question is saying, is this an appropriate medication for this particular patient with this particular set of medical conditions or psychiatric conditions to be taking? It's really important if you detect additional health considerations, conditions, or medications to fully inform the physician about those. Again, if you detect or are notified that a patient has a change in their medication regimen for a medical or psychiatric condition, it's really important to make sure that the patient has shared that with the physician, or that you have shared that with the physician, in order to ensure that buprenorphine and its dosing are still appropriate for this particular patient. The third bullet covers any additional psychosocial circumstances that may impact the stability and the supportiveness of the patient's environment. Do they have stressors or relationships or supports or living situations or other issues right now that can either contribute to their treatment success or potentially inhibit their ability to safely and reliably take the medication in an office-based setting? And again, speaking of office-based settings, you really want to determine that the patient is interested in this particular setup and that they are able to follow through. Even if they're suitable, they may not be best treated in an outpatient primary care, say, context office kind of situation. And that determination is really made, again, based on the stability and the structure of the person's living situation. And finally, the 10th criteria really require the providers and the treatment team to look at their own resources available in the office to provide appropriate treatment. So has a comprehensive recovery plan been developed? Has it been coordinated between the psychosocial treatment team side as well as the physician side? And what additional resources are needed to add to that mosaic of a plan to really help the patient have the strongest setup for success from the get-go? If those resources are not available in the physician's office, then it's really important to have those liaison and cooperative relationships with local substance abuse treatment programs. And so this may be instances where treatment facilities that that had not previously encountered buprenorphine are getting questions or referrals, or at least physicians initiating some type of adjunct services for their patients. It's really important, again, for the rest of the team to have their antenna up and their radar tuned for any factors that may, or changes in the patient's status or condition that may necessitate the need to re-examine either the patient's dose or re-examine the patient's appropriateness for buprenorphine treatment overall. The first is patients who are taking high doses of benzodiazepines, who are actively using alcohol or other CNS depressants, really need to be carefully considered. The use of benzodiazepines in particular in combination with buprenorphine, especially if they're injected in the context of, say, an overdose attempt, can definitely lead to death, and that's really important. The same, to some extent, can be said for alcohol, given that it's also a sedative, hypnotic, and patients really need to address any alcohol issues and otherwise be encouraged to abstain from alcohol while they're taking buprenorphine. The second issue here is significant psychiatric comorbidity. And again, this is really going to be a case-by-case type of determination, but really needs to be evaluated how well that psychiatric condition is being managed, how stable the person is, to determine exactly what the combination treatment plan is going to be for substance abuse disorder and the psychiatric treatment, whether they're going to be staged, whether they're going to be concomitant, and again, just primarily to ensure that the patient can be safe in taking buprenorphine and can be reliably taking it independently. The third bullet covers assessing whether or not the person has had multiple previous opioid addiction treatment episodes where they've had a frequent relapse. It's really a mixed bag in this case because on the one hand, multiple relapse situations, or for lack of a better term, failure attempts, may indicate that someone is an appropriate candidate for buprenorphine. It may indicate a lack of, on the one hand, it may indicate a lack of motivation or lack of engagement, but it's really an opportunity for the team to assess what the factors were that led to those unsuccessful recovery attempts before and see where things can be tweaked. Depending on what modalities were being tried in the past, buprenorphine as a new option may be exactly what this person needs. On the other hand, it may also reflect that they're really not able to engage in this particular set of therapies where they're independently taking medication and then participating in the rest of the psychodynamic education. Changing from one treatment to a new treatment, changing from an unsuccessful treatment to a new one may be exactly what the person needs, but you just don't want to set them up for ongoing failure without looking at what some of those underlying issues are. And the fourth consideration is whether or not people have had complete non-response or just a poor response to buprenorphine treatment in the past. Again, you really want to consider what some of those factors may have been in that particular situation. This first bullet here, again, is related really to acute psychiatric issues, as we mentioned before, specifically active or ongoing and chronic suicidal or homicidal ideation or attempts. It's also important to consider what needs the patient has that can't be addressed given any current office-based resources or through appropriate and meaningful referrals. If a patient has outstanding issues and that particular office does not have the ability to comprehensively address those issues, then they may need to be referred elsewhere for higher level of care or different treatment modality. The physician also needs to really consult with the treatment team in situations where patients have a high risk for relapse back to opioid use. For example, people who are still living in a situation or a place where other people are using heroin or other issues. And in some cases, it's just an issue of timing, getting the person established. They may need a more structured environment temporarily or for a longer period of time, something like residential care, or they may, in essence, be saying that they're not, indirectly saying that they're not ready to enter treatment. It just really depends. And in a related vein, having patients that really just have a lousy social support system. It's not conducive to anyone's recovery process, and this is a place where the treatment team really needs to confer with the physician and work with the patient together to develop a plan for strengthening and increasing their ongoing effective and other sober support mechanisms. I do want to talk specifically about pregnancy-related considerations as well. I need to make the statement that methadone maintenance does remain the treatment of choice for women who are pregnant and opioid dependent. Pregnancy in and of itself is a physical strain as well as an emotional trauma or challenge, I should say, particularly if the woman's already experiencing things like morning sickness or other minor pregnancy complications. So it's just generally not recommended for a woman who's already in a physically or emotionally vulnerable condition to go through any additional trauma or discomfort of withdrawing from an opioid. If withdrawal is indicated in the treatment plan, most physicians are going to urge the patient to wait until after delivery. And for these women, in these cases, methadone plus behavioral treatment would be considered for the immediate treatment plan until delivery. Buprenorphine may eventually be useful in pregnancy, but it's not currently FDA approved. There is no evidence of harmful effects of buprenorphine in pregnancy, but in the absence of enough controlled clinical trials, the risk can't be entirely ruled out. Buprenorphine is currently a Category C medication, and this means it's not approved for use in pregnancy. But the studies up to this point do suggest that buprenorphine may be an excellent option for pregnant women. There are randomized trials that are underway to determine its safety and its effectiveness during pregnancy. There's just really a limited amount of research primarily been done outside the U.S. There's a case series that had been conducted in France where buprenorphine was found to be safe and effective and potentially helpful in reducing neonatal abstinence syndrome. There's also been a preliminary study in the U.S. By Jones and colleagues in 2005, which looked at using buprenorphine versus methadone in the treatment of opioid-dependent patients and its effects on neonatal abstinence syndrome. It was done as a head-to-head randomized blinded comparison between methadone and bup in pregnant women who were admitted to the study during their second trimester. One of the statistically significant findings was that the length of hospitalization was shorter for buprenorphine-exposed neonates than for neonates that had been exposed to methadone. There were some trends, but not statistically significant findings, that fewer of the buprenorphine-exposed infants were treated for abstinence syndrome, and of those who were treated, less medication was needed than for the infants who had been exposed to methadone. The results suggest that buprenorphine isn't inferior to methadone on outcome measures related to neonatal abstinence syndrome, as well as safety for the mother, safety for the neonate, when it's administered starting in the second trimester of pregnancy. I know that there's a multi-site trial. Rich, do you know the results of the mother trial at this point?
I mean, people can, and we can get them a link if they want, refer to the New England Journal of Medicine, you know, about this. What I'm hearing is that possibly as soon as within a year, the recommendations about, you know, could buprenorphine be safely used for pregnancy may change. I don't know if the Category C will change, but I am hearing that it may, you know, have the FDA indications changed within a year's time. The other thing I just wanted to jump in and mention is that most of the clinicians, when giving buprenorphine to pregnant women have decided to give the Subutex version without the naltrexone in it because there had been some concerns about the pregnancy and knowing that there would be safety at the time of birth, including about any congenital defects when there was exposure to the naltrexone part of it rather than, the per se the opiate part of it.
Exactly. Thank you for making that clear, that Subutex is the preferred product in cases where we're talking about buprenorphine use in pregnancy. Thank you for making that point. It's just the mono product, not the combination product. So it's important to remember that, again, methadone maintenance is still the treatment of choice and the standard of care in the U.S. We will pull any updated findings and present those at the next webinar. But for now, we need to just restate that buprenorphine treatment is possible, but that there really, at this time, is lacking evidence and that the policies may be changing within the next year or two. So that will be important to keep an eye on. Again, it's important to use the mono product to minimize any chance of precipitated withdrawal. And remember that detox is generally contraindicated for pregnant women unless it's done in a hospital setting where the baby and the patient can be carefully monitored.
I'm going to jump in again, and there's just about nobody I've ever run into who felt detoxification off of opiates during pregnancy was a good idea unless it was the only possible way to save a mom's life. But that doesn't mean that you won't have some individuals who need detoxification, let's say from benzodiazepines or alcohol while pregnant. But there would not be, under all the circumstances I can usually think of, there would not be detoxification off of opiates until after delivery.
Yes, I hadn't experienced, hadn't had a case where I had ever clinically encountered that either, even in a high-risk OB setting in Baltimore. So that would be I would echo that.
And I'd ask our audience if they spot it happening. They really should, as clinicians, be questioning it because I have, sad to say, run into a couple of circumstances where a treatment center was not in the know and went ahead, basing it on their patient's request, went ahead and did a detoxification. Even then, I don't think that was a good idea.
Thank you. I want to cover some additional issues regarding patient selection that also need consideration with the physicians. These are not exclusionary criteria, but they are important to work in conjunction with the physician to make sure that buprenorphine is the best medication for patients. The first condition is seizure disorder. Seizures can occur with some opioids, so while these haven't necessarily been seen with buprenorphine, it's important that careful evaluation of the person's seizure disorder status be made. In terms of HIV and other Hep C and other sexually transmitted diseases, HIV and Hep C are some of the most important to consider for opioid-addicted patients. People need to determine when patients were last tested for HIV and Hep C, and if they haven't been tested recently, they need to be referred to a physician or a testing site where that can be done. It's important to note whatever antiretroviral therapies or other HIV or Hep C-related medication someone may be taking to do appropriate dosing and just really help ensure adherence across the board with all medications. There are some metabolic pathways that buprenorphine utilizes, specifically the cytochrome P450 pathway, the enzyme system, and it can really impact the way that antiretroviral medications are metabolized because they're working in the same liver enzyme system. Protease inhibitors, specifically medications for HIV, the buprenorphine can impact the metabolism of those when they're combined. So you need to potentially monitor therapeutic blood levels of the different drugs. This is not to say that it's a complete contraindication, just that patients who are HIV positive, who are taking antiretrovirals and buprenorphine, need to have their drug levels carefully monitored. With respect to bullet 4, again, this point, we're just trying to nail home again that the use of alcohol, stimulants, and other sedative hypnotics needs to be carefully evaluated. What other concomitant drug use patients have going on, particularly given the fact that the overdoses that have been reported have been related to a combination of CNS depressants and buprenorphine. The final thing to remember here is that other drugs, buprenorphine is a treatment for opioid addiction, not for other substance use disorders. And so we know that addiction to other drugs, like stimulants or sedatives, is going to be common and can interfere with people's overall adherence and engagement in the recovery process. So patients are really encouraged to abstain from all other drug use while they're getting buprenorphine treatment. And while ongoing drug use is generally, a predictor of poor adherence, it's not necessarily an absolute contraindication to buprenorphine treatment. It just may mean that people need a higher level in the intensity of the care that they're receiving.
Yeah. All right, I'm going to jump
There
in.
are some instances where people who do not meet full criteria for opioid addiction might still be candidates for treatment with buprenorphine. This is patients who are at risk of progressing to addiction, patients who are injecting, and people who have had their medication discontinued and are now at a high risk for relapse. As I mentioned before, the best example of that would be incarcerated individuals, particularly those who were successfully maintained earlier on buprenorphine treatment. The rest of the multidisciplinary team can have a lot of impact and influence over the physician's decision to decide whether or not someone is suitable, even though that the other professionals are not individually responsible for determining that suitability. The relevance to the rest of the team is that, again, patients' appropriateness for buprenorphine may change over time as their situations change. Other patients or providers may be asking your opinion on whether or not this is an appropriate medication for them. And ultimately, you need to be able to communicate effectively with the physician about any changes in status or concerns that you're observing elsewhere in the treatment program. At this point, again, we're not going to show the video because of some of the difficulties in streaming it during a webinar, but we're going to provide you with the link to the video that's called Put Your Smack Down. It's developed by the Oasis Clinic in Oakland, California, and it shows people talking about their direct experience taking buprenorphine. A couple caveats about the video. It's about 10 minutes long. It does present a really nice patient perspective, but the population is, you just need to keep in mind, the population is an urban population in California, predominantly IV heroin users. And there are some patients in the video that express comments that can come across as if buprenorphine should replace methadone. And as I've mentioned before, we really want to send the message that this is one option for treatment. We're not advocating it as a replacement for any kind of existing treatment modalities. And as I had mentioned before, there's some discussion at this particular clinic about needing to wait a full 24 hours before starting the induction process. And again, that is one way of doing it. It's this particular facility's approach, but for the shorter acting opiates, 6 hours can be sufficient. For the longer acting opioids, like if someone's on methadone, you definitely do want to wait more towards that 24-hour period. And the best way is, again, to use a structured and validated opioid withdrawal assessment tool. I would encourage you to watch the video, though, on your own, because it really does give some of the first-hand experience of what it's like to use buprenorphine and then be maintained on it. So I do want to leave some time for questions. I know we had some leftover questions from the previous module, and then I want to leave some time to answer any questions that you may have regarding this module. So it looks like we have about 10 or 11 minutes left. I'm just going to summarize in conclusion here and then take whatever questions you have. So in general, not all opioid-addicted patients are good candidates for office-based buprenorphine. We went over the 10 criteria that are important assessment questions to really think about in conjunction with the physician to determine whether or not this is the appropriate treatment modality for patients. People who do have certain medical or psychiatric conditions, in particular medical conditions like HIV or Hep C, need to be carefully screened by a physician prior to being started on buprenorphine, and then given whatever medication regimen they're on for those conditions, may need to have the blood levels of their other medications carefully monitored. So at this time, I'm going to stop, and Christine, if we could start with some of the questions that were left over from Module 3 and then move down into any that are related to Module 4.
Sure. The first one is there a maximum milligram that creates a ceiling effect that Suboxone is no longer effective, or when it levels off?
Hi, this is Rich Silbert again. When we talked about this before, there's some individual differences among the docs that have been the prescribers, what they feel the maximum is. Usually hear about 32 milligrams for the ceiling effect. Some have felt it was a bit less. But basically, if I understand the question correctly, there's not been a lot of research, just anecdotal experience that sometimes going higher than 32 led to just more negative kinds of feelings or dysphoria rather than any kind of positive outcome of it.
Yes, and the notes that that I have in the trainer's manual don't have a citation for the fact regarding that at 16 milligrams of the medication, about 95% of the receptor sites are occupied, and then once you go up to 24 milligrams, it's about 99%. So I think that Rich is right in that at this point it's really it's ultimately a provider decision, but that pharmacologically speaking, once you start going above 24, it's really unlikely that there would be any added effect simply because the receptor sites are already full, and that you could in fact have a deleterious effect instead. And
a lot of insurance companies won't cover, beyond 24 milligrams, and some are thinking about 16 milligrams, and basically it may invite diversion because there'll be more than is absolutely necessary. So topics still to be covered.
Okay. If a person is clean and sober of all drugs for a year and due to psychosocial stressors experiencing cravings of the drug of choice, which is opiates, would you recommend Suboxone?
Yeah, I think kind of a similar question at the end of the last module, or the break, I should say. was asked. And I personally, I do feel that, and I think Lauren had already presented that there are some situations where addiction is more than just a physical dependence. And there are some situations where if you see the outcomes being extremely risky and poor, that it may well be appropriate to go on buprenorphine maintenance treatment at that point. My experience usually have been that you would do that with much lower doses than typically we've talked about otherwise.
Okay. If a buprenorphine patient is in an outpatient treatment program and they're working towards tapering off Suboxone towards a drug-free lifestyle, and they left treatment only to discover a week later that they are struggling with physical and mental cravings and requested to re-enter treatment, is it necessary for them to test positive for opiates or Suboxone at the time they would re-enter treatment a week later? It says, I was advised that they must test positive in order to re-enter. What is your opinion on this?
I know of no federal regulations, or whether it be DEA or otherwise, that would require that for that. It may have to do with certain third-party payers or insurance company if they've got certain stipulations on this. I would think it would be inadvisable to hold that individual to that kind of criteria. I just want to add one other comment because it's such an interesting question. We do know, as was indicated in the presentation today, that if an individual stops their medication-assisted treatment either too soon, or even if they stop it sometimes a year or two into things, the outcomes haven't always been positive. A lot of times outcomes, have included relapsing. And one of the things that probably needs to be looked into further is when people do this, do they do that because they're experiencing some at least mild to modest withdrawal, even if they're coming off 2 milligrams of buprenorphine? Is that the biggest factor that leads to a failure, or has their neurons and their whole kind of brain chemistry been so permanently affected by opiate dependency that it really was a mistake to do this? So again, more studies, more outcomes have to be determined, but current thinking has said that be careful if you're going to do that after an extended period of time. There will be some withdrawal, and there will be some folks who always have poor outcomes in relapse.
In terms of referrals after rehab on meth, sub, bup, and others, most often it's a client's request because they are starting a 12-step program and want to be defined as clean. After long-term programs tend to, also long-term programs tend to get individuals who failed on a prior treatment at lower levels of care, such as you are on meth but have relapsed, so the level of care is being bumped up. In such cases, detoxing makes sense. The only other reason we have detoxed is a request by the client due to legal stipulations. Otherwise, we would refer to ongoing care.
I mean, there still are court stipulations that have I think we're seeing less and less of it, but we still do see some drug courts that won't support the buprenorphine and medication-assisted treatment, or in some cases methadone-assisted treatment. We don't see that as much these days, but and we already talked about certain jobs that mainly the physician job, and we're going to check out about the pilots that won't allow it. The only other circumstances I've had was a woman who was deciding she wanted to get pregnant and have a child and just felt most comfortable about doing that without staying on Suboxone. She did okay, but she also decided, because of how many cravings and relapse issues she was having right after delivery, she did go back on the buprenorphine medication-assisted treatment after delivering.
Some patients report being prescribed buprenorphine by pain clinics for pain management and addiction to pain meds. What is your opinion on patients being prescribed this medication for pain management?
Well, it's again a very good question, probably a complicated one that there needs to be more study and gathering information. Personally, I think that when you look at opiate dependency, there is a very large segment of the population that are in chronic pain, and they tend to do very, very well on buprenorphine treatment. And so I think it's a very important part when done kind of in the way we've talked about today. What I don't like is the stories I sometimes hear about a pain clinic kind of dispensing it as if it's individual analgesic. The amount of analgesia that you can get from buprenorphine, it's not as much as some other opiates, but there certainly is some analgesia, and there certainly has been some success with the opiate-dependent folks.
Yeah, I would concur with that. At least in the inpatient acute care medical setting, there were patients that were able to get adequate coverage of both, in most cases, soft tissue infections related to injection use. Were able to get adequate pain relief from buprenorphine and a non-opioid supplement, able to get coverage for both pain and withdrawal symptoms. But again, it tends to be highly individualized and based on the type of pain and other medical condition that the patient has going on.
And the most complicated situation is somebody who's been successfully maintained on buprenorphine. Let's say they're at 16 milligrams and has surgery and comes out of surgery. Those tend to be the most challenging decisions about like what to do, whether to stop the buprenorphine and give other opiates, or to do what Lauren just said, to give it and give some other kinds of pain relieving medications.
Yeah, I think you bring up a really important point, too, in terms of patients themselves or their family members needing to be advocates in acute pain or emergency situations, as well as perhaps, other members of the treatment team, because a lot of ER providers are not, or trauma center providers are not necessarily aware of buprenorphine or its effects and how to manage an acute pain situation when you have someone who's maintained on buprenorphine, because ultimately, again, because the buprenorphine is binding so tightly, you're going to have some difficulty ensuring adequate analgesia for a while.
Right. Absolutely.
There are two questions here concerning breastfeeding. The first is, can buprenorphine be used safely while breastfeeding?
I've got to go back and research that again. I'm wondering if there's enough studies that have been done to establish it. So I think I better not answer right now. We'll get
I want to actually look back at specifically the work of a colleague here in Pittsburgh who had been looking at methadone safety in breastfeeding, and I can't remember whether or not buprenorphine is included in that trial, but I'm just adding that to my list for next time. That's a great question.
Great. We'll get that to you.
Is it safe for a mother to breastfeed while on Suboxone, or should she remain on Subutex?
Yeah, I mean, again, we better research that rather than just give an answer. I mean, I know the obstetricians and gynecologists are always telling me they would prefer not, but there's always these risks versus benefits kind of issue, and obviously if a baby had a mom who was actively abusing opiates, which is the much less of two evils, so let's try to get you some outcomes studies if there are, but certainly on a personal basis, I feel it was a much safer deal than being on street drugs and breastfeeding.
Yeah, and I would concur also that the breastfeeding is just so important, especially for it's important for all infants, but important especially for high-risk infants, and also to help support postpartum bonding between mother and child. That can be just especially difficult for folks who have substance use disorders. So the breastfeeding just facilitates so many physical as well as parental-child attachment bonding kind of issues. So thank you for raising that question, and we'll clarify that for you during the next session.
Okay, and we can close up with this very last question. Many drug-free workplace policies mandate the report of use of mood-altering prescription drugs. In your opinion, would use of this drug fall into that category?
You know what, in my opinion, no, but I'm not a lawyer or an industry expert, but in my opinion, no. But I'm sure other people could take issue with that.
Okay, well, that's it for me.
Okay, thank you all for participating. Our last session will be on November 9th. Please, if you have any questions that arise in the meantime, feel free to email them to Christine or jot them down and save them for the next session. You guys are just really asking very thoughtful and practically oriented questions, and for the ones that we weren't able to answer, we're committed to finding those out for you and reporting back at the next session. Thank you again.
Thank you.
Okay, at this time we will end this webinar, and you will be receiving the link to the video, and within the week or so you'll be receiving your links on to the next session. Thank you.